And good afternoon, everyone. And today I'm going to share the experience in terms of universal healthcare coverage in Thailand. As you listen to Professor Ann Mills mention a little bit this morning about Thailand already, so we will, reinstate on some of the issues that she stated there as well. Okay, as you may be aware that Thailand is a developing country, and we are in the middle income country, and the population is around 67 million people. We have the administrative areas in provinces, 76 provinces. The gross national income per capita, PPP, is about 9,280. And growth GDP for the year 2014 is about 5.1. Okay, and total expenditure on health per capita is about 386, and percent total health expenditure of GDP in 2015 is about 3.9. Life expectancy at birth, for male and female is 71 to 79. Now, let's look back into the historical part of the national health account, universal health coverage of Thailand, historical development. So since the beginning, in 1945, we used the user fee, and you look at the left-hand side, health infrastructure. We emphasize on building health infrastructure since 1962 to 1976. During that time, we established provincial hospitals, and later on in 1977 to 1986, we established district hospitals, health centers. So from the province to district, so that's what we had done earlier. And then in 1975, the low-income card has been established during that time, including in 1980, CSMBS, which is the Civil Servant Medical Benefit Scheme, has been introduced then. So it started with the informal exemption, then followed by the establishment of the prepayment schemes later on, okay, in terms of the SSS, CSMBS, the medical welfare scheme, and so on. And then later on, until the year 2001, we have the universal health care coverage, which is including of three schemes. The universal coverage, and then we have social security scheme, and then we have the civil servant medical benefit scheme. So before 2002, 30% of the entire Thai population of 63 million people remain uninsured. But later on, with the advent of the universal healthcare coverage scheme, that's combined medical welfare, low-income card scheme, and government-subsidized voluntary healthcare scheme, with coverage extension to the remaining uninsured. So therefore, Thailand achieved the status of universal healthcare coverage in the year 2002 in terms of insurance entitlement, when the gross national income per capita was just only 1,900 during that time. For universal health coverage, in terms of the policies context, two broad strands of health systems development were applied well before the UC scheme. As I mentioned to you before that, we have the expansion of the infrastructure and human resources to district health system during the year 1970s to 1980s. The second part, the extension of financial risk protection from 1975 onward, targeting different groups of the population. This development results in high level of health service utilization with narrow socio-economics then. The tax finance universal care scheme is progressive in Thailand, and a closed-end provider payment contributes to cost containment and system efficiency. While it was financially feasible to offer a comprehensive benefits package at the launch of the UC scheme in 2002. A few high cost services, in particular, for example, like antiviral treatment and renal replacement therapy, were introduced later as well in the year 2003 and 2006, respectively. This table shows the comparison of system design between the UC scheme and a social health insurance. So you can see that, and you can compare in terms of the benefits between these two, which somehow are not the same, okay, and different services and treatment were included in different scheme in here. And of course, there is another one, which is the CSMBS, or Civil Servant Medical Benefit Scheme. For fiscal costs to the main health insurance scheme in Thailand, in terms of the percentage of the GDP, you can see that the UC is the highest one, followed by the CSMBS, which is the Civil Servant Medical Benefit Scheme, and then followed by the Social Security Scheme. In Thailand, we have one of the key success of the system in Thailand is that we have monitoring and evaluation of the universal healthcare coverage. But at the beginning, at the inception of the UC scheme, there were no explicit monitoring and evaluation, or M&E blueprints. Development of the information system and the M&E indicators have been incrementally built to existing platforms. A high coverage of a civil registration of 76.7% of births and 95.2% of deaths facilitates UC monitoring. The sharing of interoperability of health insurance member database across the three schemes not only contributes to the accurate head counts, but ensure the entitlement of the covered health services as well. So there are existing national representative household surveys in Thailand, 3 of them. The first one is the health and welfare surveys, and followed by the socio-economic surveys, SES, and alongside of the national health account. So these are the main components of the assessment that we have of the overall level and distribution of health utilization benefits in this incidence, and also look at the financial risk protection. National Health Examination Surveys, or NHES, locally initiate and finance contribute to measurements of effective coverage of key chronic and non-communicable diseases as well. Routine administrative data, various disease registries were established in response to program management requirements. For the progress towards UHC in Thailand, existing evidence demonstrate basically favorable universal healthcare coverage outcomes in terms of the equitable access to health services, a low level of unmet health needs, and high level of financial risk protection. Since the early 2000s, all Health Millennium Development Goals has been achieved, reflecting the health system's resilience and capacities. During that time, Thailand ranked first among 80 countries with the highest average annual reduction, 8.57, in child mortality between 1990 to 2006. In terms of the financial risk protection, direct health payments by household fell gradually from 45% of total health spending in 1994 to 35% before UHC achievement, and less than 20% less after the UC scheme, 30 baht scheme during that time. Co-payment was abandoned in 2006 and to less than 50% in the year 2010. Incidents of catastrophic health expenditures measured by the out-of-pocket, which is greater than 10% of total household spending, decreased substantially from 6% in 1996 to 3 to 4% in the first decades of the universal healthcare coverage in Thailand. There was a marked drop in the number of households impoverishment by health payment after universal health coverage was achieved. You can see from the pictures, figure 1 right here, the number of households prevented from medical impoverishment, okay, is reducing, okay, until the year 2009. So as a measure of the service utilization, annual per capita outpatient visits and inpatient admission have increased from around 2.4 and 0.067 respectively in 2003 to 3.22 and 0.12 in 2009 and to 3.6 and 0.119 in 2011. Outpatient visits among the poorest quintiles of universal healthcare scheme beneficiaries were disproportionately higher, okay, than the richest counterparts. And similarly, inpatient admission were concentrated among the poorest quintiles in the population than the wealthiest quintiles in the figure 2 right here. Okay, so this one shows the health and healthcare utilization by poorest and richest beneficiaries. So despite the achievement of the universal coverage, healthcare coverage, challenge still remain for Thailand. So we found that the increased burden of the non-communicable disease is evident. Okay, series of the national health expenditure surveys shows the increased prevalence of overweight and obesity and diabetes in both male and female adults over the last 2 decades. The cost pressure to all schemes from an increased demand and long-term treatments prompts policy attention towards effective primary, secondaries, and tertiary preventions, and priority non-communicable disease which address the social determinants of unhealthy lifestyles. So the local initiate of the finance of the universal healthcare coverage, which is independent from donors, resources, and agendas, ensure sustainability. Continual improvement of course, a monitoring and evaluation system that are used for policy decision in line with national interests are the main features of the Thai experience. Factors contributing to these features are institutional capacities to generate evidence and influence policies, monitoring and evaluation with effective feedback for adjustment, economic growth and improved fiscal space, political and financial commitment, implementations, capacities and supply side resilience to accommodate significant increase in service utilization. The monitoring and evaluating a data platform should be sustained and strengthened, although we have surveys that we have are adequate in measuring the financial risk protection and utilization, but they cannot monitor the effective coverage. So some of the key biomarkers, such as blood sugar and for diabetes and blood pressure for hypertension captured by the National Health Expenditure Surveys, perhaps are needed. And self-report unmet health care need embedded into the health welfare surveys, although subject to difference in expectation and useful and should be continued. So finally, why the hospital waiting times for key interventions are recorded in hospital-level logbooks. It is done with great variation and definition and measurement and should be standardized and scaled up nationally. Now, the lesson learned and conclusion from the Thai experience in here. You all realize that Thailand is not a single scheme universal healthcare coverage. We are the multi, a scheme which is consisted of UC coverage fund, the social health insurance, and then civil servant medical benefit scheme. Thailand also well-developed purchasers provider split, okay, with the independent UC fund established by legislation with a multi-stakeholders governing body, including private and civil society representatives. And it is its internal structure operating systems, procedures, and information technology are firmly established, accessible, and affordable in the middle-income country context. Fund will initially focus mainly on public sector's provision, but will progressively explore mixed public and private provision option as well in this coming near future. Despite a very sophisticated population registration, reimbursement, and audit system, the administration costs of the Thai UC fund is remarkably efficient, 1.2% of its total annual budget. The National Health Security Office, which manages the UC fund, concentrates on the pooling and strategic purchasing. It has no revenue collecting function as the scheme is financed through an annual budget. So the success of the UC fund is such that the CSMBS, which is the Civil Servant Medical Benefit Scheme, and Social Security have adopted a number of its systems. So we use the DRG system in this. In addition to the National Health Security Office manage the disease prevention and health promotion budget for all Thai citizens, assisting the other scheme and providing a strong focus on prevention and promotion at the same time beyond the conventional scope of insurance. Thailand for several years had implemented and refined on reimbursement reform and put in place a system of capitation for primary care and the DRGs for hospital inpatient in order to contain hospital spending, adjust for case mix severities, fund primary care more equitably, and improve technical efficiency. Thailand's civic registration systems operate mainly through the national ID cards, which all the Thais will have that one, and is an impressive sign of citizenship. So all citizens are visible along with their health providers unit in the electronic system of the UC fund at every hospital and also the primary care centers. Thai capitation system use an interesting contracting unit called CUPS. So this CUPS stand for contracting unit for primary care, which is, of course, the district hospitals along with its referring primary care centers. So this part is quite unique because Thailand primary healthcare system is quite complete to a certain extent. And the Thai DRG system now in its version of 5.1, which is well developed as well. At the same time, both hospitals and health centers in Thailand have their own bank accounts and can retain surplus revenue for operations and additional incentives for staff. It decentralized holding of fund has provided greater flexibilities to health facilities to solve local problems. Thailand has a very deep primary care system, as I mentioned to you before, with over 10,000 public health centers and approximately 1 center per 6,000 Thais. In addition to nursing and public health officers, each health center has up to 30 community health volunteers who also work closely with health centers and local government on prevention and promotion. Substantial investments were made in infrastructure for rural health centers, often using attractive but standardized design option, lowering infrastructure costs. Thailand has achieved impressive health outcomes. Okay, that's one of the keys, and as well as the financial risk protection and universal coverage with advanced reimbursement system at remarkably low cost. With the progression towards universal coverage, public health expenditures has grown from only 3.4% of the GDP in 2005 to 5.6% in 2014, and total health expenditure from 4.6% to 6.5%. Many factors contribute to its low cost, particularly on the supply side. Total inpatient payments using DRGs are capped. Primary care spending is limited by the capitation mechanism, and there is a substantial use of central procurement of certain high-cost medicine by National Health Security Office and use the generic medicines by contractor providers. The primary care system is highly accessible. Patients who bypass their registered CUPs are viable to pay full user fees by themselves, and CUPs fund holding is applied by which higher level hospital can bill lower level hospital for OPD services. It means that money will follow the patients to different places. The use of one main large UC fund simplifies administration, of course, a relatively low wage cost, along with the strong work ethics and the use of mainly public providers contribute to the low costs. So there is sophisticated process of institutional capacities for health technology assessment using economic evaluation techniques before new expensive intervention and medicines are included in the benefit package of the UC funds. This is one of the nice characteristics about the UCs in Thailand. The Ministry of Public Health and the UC's fund are supported by the numbers of independent or semi-independent institutions that provides independent technical support. And these include, among others, the International Health Policy Programs and its capacity development arms of USC's and Health Intervention and Technology Assessment Program, which is we call HITAP, which undertake economics evaluation of new intervention. The Center of Health Equity Monitoring and the Thai Case Mix Center, which develop and refine the DRG systems. So the Thai Health Foundation and the Health Care Accreditation Institute. So all of these organizations help the Ministry of Health and the UC Fund in order to support with the information related to the technology assessment of all the treatments, all the medications, and so on. So other countries could benefit from a health technology assessment institute like in Thailand as well. And although the Thai UC system use mainly public provision, public primary healthcare in urban cities remains weak to a certain extent, while the private sectors concentrates on tertiary specialized care. Okay? Now, So this is going to wrap up to the end because my time is up already. Thailand has a strong market economy and that has achieved large GDP improvement over 2 decades, rising from low income to upper middle income countries. And it has relatively small private sectors, which is like 25 and 21% of the hospital beds, respectively. And we will challenge to find a more diverse provision mix and wealthier urban population growth. So this is basically the big pictures about Thai universal healthcare coverage in a nutshell for you. We can open for discussion, or since Professor Ann Mills is here, so she might be able to add on in terms of the suggestion and a lot of things that she can input for us as well in here. This is the reference that you might be able to go back and read it if you would like to take a look at it more into details. And thank you very much for the attention.